Hello everyone, I'm Vasileia Kostaridou. I'm working as a project officer in the Athens Office of Quality of Care and Patient Safety Office, and I'm going to present to you our work on quality indicators and how we scope to incorporate also artificial intelligence and advanced analytics. On my team, of course, is Dr. João Breda, who is the head of the office, Dr. Henrique Martins, who is very valuable, Christos Triantafylou, Bruno Trigo from Portugal also, and Anastasia Dikoudia, amongst others. And I would like to acknowledge their help. So what is Health IQ and how we are planning to advance healthcare quality in Greece and beyond, because it is a program that we plan to implement in Europe. It was inspired by WHO European Programme of 2020-2025 in partnership with the Hellenic Republic National Development Programme. Its objective is to develop a framework to measure and enhance healthcare quality via specific indicators that reflect quality of care. So it is patient-centered, and this means that we're trying to target all aspects of healthcare: primary care, hospital, long-term, mental health, public health access, and non-communicable disease prevention. And what we are hoping to have an impact on and how we're going to innovate is that we are focusing on quality measurement and improvement via establishing performance and patient feedback mechanisms. And we want to enhance cost-effective and equitable systems by ensuring efficient and accessible healthcare. And then, once it is finished, we hope to have some regional dissemination by sharing these best practices and quality standards across the WHO European region. So, what actually are these health quality indicators, and how are we planning to measure what matters? First of all, we want to align all stakeholders around patient benefits, and it is a three-tier indicator framework. We are collecting all possible health indicators that we have found in specific workgroups that we made, also in literature and all the state-of-the-art. Then we have a refined set of measurable indicators that we identify that can be measured effectively. And then there are also key indicators for policymakers and stakeholders. And all this information is going to be incorporated in an ICT platform for quality of care. So there will be data acquisition and integrated system for collecting health data from all stakeholders. And there we'll have also the principle of data reuse. Then we're going to have the next step, indicator calculation. We're going to be processing data at individual health unit and national levels. And then we're going to assess the indicators. We're going to leverage data mining and machine learning for in-depth analysis. So we have the scientific background to develop the indicators, and then we have the help of ICT technology to develop a platform to measure them. So for this purpose, we came up with the idea of proxy indicators. So as we all know, data is raw alphanumeric values. In ICT world, it's just binary, 0, 1. Information is the next level, so it is created when data is processed, organized, or structured to provide context and meaning. So it's the next step of transformation, data to information. And then comes knowledge, what we aspire to achieve. Knowledge is unique to each individual. It's accumulation of past experience, data input, and insights. It's what shapes the lens by which we interpret and assign meaning to information. So we hope to transform data to information, and this to give us some knowledge on quality of care. So how do we plan to collect the indicators? First of all, we have the manual indicators, where we will have data manually collected directly. This will be either in paper or Excel, and it will be very direct. People will be assigned to this and trained. Then we have some automated indicators that will be created by processing data collected for other purposes, such as from electronic health records. And these automated indicators will be, of course, in collaboration with Greek organizations. And then we have the proxy indicators that I will be talking about. So the data for these indicators will be created through mathematical inferences from other data. And of course, their exact variability and error and an error margin should exist. Okay, so We have the manual indicators, the automated indicators are going to collect, and also this proxy, the synthetic indicators that we are going to create. And so these proxy indicators, they're going to point towards a value. They will offer an estimate. So we decided, and we thought of the idea of the proxy indicators, because the manual indicators, in order to collect manual indicators for healthcare, is expensive, it's time-consuming, it's also intrusive in the healthcare professionals' busy schedules alive, and it was difficult to roll out across all country. And of course, it's too slow to implement. So there we will be having a dual approach as the program will be developing, collect the actual indicators that will be collected directly from hospitals and other Greek institutions. It will be manual or automated, as I said before. And then on the parallel, we will be having the proxy indicators that we will be developed through exploratory data analysis and predictive modeling that will be validated against the automated or manual indicators. So what will the proxy indicators offer to the program? The validation of actual indicators. So while we will be collecting the manual and the automated indicators, we will be developing also the proxy in order to cross-validate and verify the collection of real-world data. So we will ensure that hospital indicators reflect real outcomes, and we will also cross-check the manual data. Also, accuracy and reliability. We hope to reduce reporting biases and errors, and to have objective and data-driven alternatives. Also, by the implementation of some machine learning, we're hoping to have some predictive insights and early warnings, maybe to identify and anticipate safety risks, and do some proactive interventions. Also, by automating and having proxy indicators, we're hoping to reduce the manual reporting burden of the healthcare workers, and also to enable some real-time monitoring, because manually it's difficult. You have to collect the data manually and then process them, and it takes some time. Also, we hope to identify patterns and trends, identify hidden safety risks, and support evidence-based policies. So how did this start? The actual implementation of the idea of proxy indicators. We got some initial data sources from our colleagues at the Greek Institute of DRG that were records from, with the kind permission, of course, they were records from hospitals. These were admission dates, length of stay, discharge and admission reasons, age, gender, length of stay. We also got for each record the corresponding ICD-10 codes and their DRGs. And also we mapped for the ICD-10 codes with the patient safety indicators. For those who don't know, patient safety indicators are in literature. They are standardized metrics that were developed by the Healthcare Research and Quality Institute, but they have been supported also by other hospitals in Europe. And they identify potential adverse events and complications that occur in healthcare settings. These are derived from administrative data, and we were able to map these PSIs, the patient safety indicators. I will show in the next slides what they are. We mapped them directly to ICD-10s, and then we could explore the data that we had in various ways. Also, we explored the length of stay distribution by age, discharge region, admission region, age group, and we were able also to identify high-risk conditions in relation to the patient safety indicators. So, as a first step, we got these records from the hospitals. We used the patient safety indicators, and we just did some initiatory, let's say, analysis to see how we could develop these proxy indicators. So the methodology we had was first data collection and pre-processing, gathering the raw hospital data, as I said before, ICD-10 codes, patient records, admissions, outcomes. We cleaned and standardized the data sets to be consistent, and we aligned the raw data with the hospital-reported actual indicators for comparisons. Then the next step is to do the exploratory data analysis to identify trends and anomalies in the raw data that may influence patient safety. Then we would compare the raw data to manually reported quality indicators for the initial validation. A next step would be to do some mathematical modeling for the proxy indicators. So we scope to design synthetic indicators that will approximate the actual patient safety metrics. We also hope to develop, and we will be developing, statistical validation methods to assess alignment with the real-world events, and to establish thresholds and benchmarks for comparing proxy indicators against actual hospital-reported values. And the last step, that it is also the most exciting for me, at least, is to implement some machine learning from predictive and classification tasks. So once we collect this data, we train them, we develop the proxy indicators for the validation first. Then we hope to train machine learning models, for example, random forests or gradient boosting, to detect if there are any patterns in these patient safety risks, how these indicators change in time, over months at the hospital, how do they change with age, how do they change with the length of stay, how does it affect, how does gender affect quality of care. So then we will use these proxy indicators as predictive variables to validate and refine also the actual indicators. So imagine that we will be collecting the actual indicators, and then we want to transpose the proxy indicators to see if they align. And then we can assess in the end if these proxy indicators that we will have developed can fully replace or enhance the manual ones for real-time insights. And then we can also assess how they respond to different hospital scenarios, including patient demographics and clinical variations. So some of our preliminary results are from this initial data set that was provided by the Greek DRG Institute. We calculated the most frequent ICD-10s, and then we connected them with the most frequent PSIs that we have from literature. So we saw that the most frequent risk was cardiac complications, hospital-acquired infections, and severe threats to major vital organs and respiratory complications. These were the first 4 frequent patient safety risks that were derived from the ICD-10s. And this was from a very basic initial data set, so we're expecting many more outcomes. And we also did this distribution of risks that for various age categories. We used the age group categories. They are not shown very well here, but they are derived from WHO's also literature. They are not, we did not decide them, they're literature-based, sorry. And one very interesting thing is that we did a heat map that was the average length of stay by age group and discharge region, which had some really interesting insights. I'm not clinical to explain them, but it has some valuable, this is knowledge. So we took the data, we organized them in information, and we did the heat maps and the diagrams that provide the knowledge, or that will create the knowledge in the clinicals. So we initially started with a small data set that gave us quantitative results, and then we received some more data, and then we have more insightful, accurate, and more accurate results, because more data means higher accuracy. And here is a heat map we have created, which is the length of stay per age group, per various hospitals. It is qualitative information now because we know what the hospitals are, so we know what to expect. But also there are some outliers that are very interesting, and this shows that it has a lot of potential. So what are the next steps? We are ongoing with our exploratory data analysis, then we're going to do the mathematical modeling. First, we will use mathematical modeling, statistical and machine learning techniques to derive proxy indicators from hospital data. Then we will do some feature engineering. This means we will identify key variables from hospital data to represent patient safety and quality, or we will implement feature engineering methods to see what are the variables that arise, let's say, from the data. Then we hope to implement predictive modeling, to implement maybe regression models, decision trees, or neural networks to estimate safety and quality metrics. Validation and cross-checking, of course, to compare the proxy indicators with the real hospital-reported data to ensure accuracy. And then to automate, to refine models over time to enable automated real-time patient safety monitoring. Because in the end, this is our scope, to have patient safety. So the outcomes we hope to achieve are reliable proxy indicators that reduce the need for manual data collection, enhanced predictive capabilities for patient safety and quality assessment, and scalable models adaptable to various healthcare facilities in Greece. Models that can be applied to all hospitals, even if they are children, for mental health, in small areas in Greece, in the Athens. And next steps are to possibly use these patient safety indicators and ICD-10 codes in all data that we collect in order to identify high-risk patients, to forecast even length of stay with decision support systems for predicting hospital stays that are based on patient demographics and their diagnosis, possibly even to suggest resource allocation, predictive models to optimize ICU bed allocation and rehabilitation planning, anomaly detection, because with machine learning we can identify outliers, we can flag the unusual patterns in hospital data, and then we can do early intervention. And then automate patient safety monitoring, which means continuous improvement through real-time data analytics. Also, with some preliminary results, we implemented on our initial data set a small random forest classifier and had an okay accuracy of 84% to identify high-risk patients with high precision and recall scores for detecting cardiac complications and hospital-acquired infections. So on our data set, we implemented this algorithm, and by using the patient safety indicators, we managed to identify them correctly, which means that if we collect more data and we have more parameters, we will be having higher accuracies. And what our scope and impact is to have improved efficiency in hospital operations, to have enhanced patient safety through early risk identification, data-driven decision-making for healthcare professionals, equity, trust, and outcomes that matter. And so, of course, because artificial intelligence is just starting to getting implemented, we all have ideas that we consider crazy, but in the near future, they might even become reality. So there are many ideas from using the convolutional neural networks for medical imaging, using diagnostics, natural language processing for clinical documentation. Maybe in the future, for our indicators, we can extract text related to diagnosis from hospital information systems, radiology information systems, laboratory information systems, diagnosis related, for example, to malignancies. And these can directly feed our indicators related to clinical data. So once, for example, a word appears that indicates something is a malignancy, this can go directly to an indicator related to cancer. But of course, this is in the future to come. Maybe we can enable AI models training across multiple hospitals while preserving, of course, data privacy, so that we have different populations to train our data, so to prevent AI bias. And then we can also have adaptive AI-driven protocols for dynamic treatment recommendations, prevention strategies. We can even assess how prevention strategies can have impact on trends. And of course, when it will be possible to be integrated with electronic health records, then we can have a seamless AI-powered workflows, and we can have real-time risk assessment. And of course, this needs all to be under the umbrella of proper governance frameworks, so that we ensure that we have responsible and effective AI implementation, and so that we hope to bridge technology and clinical expertise for safer, smarter, and proactive healthcare systems. Thank you very much. I'm sorry if I was too fast. Thank you.